Alright, so here we go. We're at week number 11. We're going to be in chapters 65, 67, and 68, I believe, talking about the neurologic system. So here's your objectives: structures and function of the central nervous system and the peripheral nervous system. Just need to be familiar with those. Go back and review from physiology. Be familiar with the parts, the structures, and how they work. Factors that affect functioning of the sympathetic and parasympathetic systems. Changes in neurologic function that are associated with aging and their impact on how you would change your neuro assessment, or what changes you would see, what findings you would see. Diagnostic testing that we would use for neuro disorders, and then your nursing care or nursing interventions that you might implement based on the findings of those tests. Okay, so just some basic review about structures and function of the nervous system. Of course, the central nervous system is made up of the brain and spinal cord. That's pretty straightforward and encompassing. The peripheral nervous system is made up of cranial nerves and spinal nerves. It incorporates both the autonomic and somatic systems. The autonomic system being your sympathetic and parasympathetic, and that refers to involuntary function. So the autonomic system really deals with and controls all those functions that we don't even think about: heart rate, respirations, coughing, sneezing, digestion, pupillary responses, things like that. Things that we don't even think about or think about controlling, that all falls under autonomic. The somatic system has to do with all of those bodily functions that we do think about. The voluntary nervous system, or voluntary control of the body, voluntary control of body movements. So somatic is like purposeful movement. So the autonomic system controls all of your motor, well, really the peripheral nervous system controls all motor, sensory, cognitive, behavioral, controls everything. Okay? Now your central nervous system is divided into some specific parts. I'm just going to kind of run over real quick. The cerebrum, which is divided into the right and left hemisphere and contains 4 lobes: the frontal, parietal, temporal, and occipital. And if you remember from physiology, that each one of these has a very specific role or specific function. The frontal lobe deals with concentration, abstract thought processes, memory storage, information storage, motor function. The frontal lobe also contains Broca's area in the left side, left hemisphere, which controls your speech production, motor function to actually form words. The frontal lobe also has to do with emotions, your affect, judgment, personality, the ability, rational thought processes, and also inhibitions. So anybody that has damage to the frontal lobe, you're going to see changes in a lot of these areas. That's why a lot of people with frontal lobe damage tend to have a very flat affect. They may not really show much emotion. Their judgment can be very limited or poor. If there's damage to Broca's area, then they've got speech problems, aphasia. So you can see how the frontal lobe is very important. The parietal lobe is known as the sensory lobe. That's where a lot of our relay and analysis of sensory information that occurs, sensory information to appropriate places in the body. So the parietal lobe is responsible for things like right and left orientation, size and shape discrimination, proprioception, things like that. So it has to do with sensory in terms of where, like for instance, knowing where your hand is in relation to the rest of your body. The temporal lobe has a lot to do with auditory receptive area. That's Wernicke's area. Temporal lobe also plays a role in memory of sounds and understanding of language. So go back to the CVA chapter and brush up on expressive and receptive aphasias, and which one goes with Broca's and which one goes with Wernicke's area, because that tells you very clearly what part of the brain is damaged. The occipital lobe has to do with all things visual and memory also. A lot of memory comes from the occipital lobe. The other important part of the central nervous system is the brainstem. That regulates all your vital functions. I know y'all remember this because we've talked about it before. Heart rate, respirations, blood pressure, cough, swallow, sneeze, the sleep-wake cycle. All basic involuntary reflexes are controlled by the brainstem. The cerebellum has to do with balance and coordination, proprioception, so even more so than parietal lobe. The real control of proprioception is the cerebellum. Okay, so somebody who has cerebellar ataxia, they're going to have problems with balance. So just remember cerebellum, balance, coordination, proprioception. Then all of those parts are encased in cerebrospinal fluid, which is supposed to be clear, colorless fluid that serves as a cushion for the brain and spinal cord. Normally there are a few white cells that are found in it, but it should never have bacteria or red blood cells. It should be clear and colorless with a few white cells, but it should never have bacteria or blood. Another important thing for you to be familiar with when we talk about the nervous system is the blood-brain barrier. This is a protective function that prevents big molecules that are circulating in the blood or circulating in plasma. The blood-brain barrier prevents those large molecules from entering into the central nervous system. So things like medicine, dye, antibiotics, all that kind of stuff is filtered out through the blood-brain barrier. So in cases of CNS dysfunction or CNS disorders, there can be an alteration of the blood-brain barrier, which would then allow those medicines or whatever the case may be, would allow it to cross over into the central nervous system, brain, and or spinal cord. Okay, we talk about the autonomic nervous system briefly. Again, that's sympathetic and parasympathetic. So sympathetic would be your fight or flight. Parasympathetic would be the rest and digest or feed and breed, however you want to remember it. So some factors that affect each of these areas. The sympathetic is basically an overproduction of adrenaline, and that results from an overstimulation of the central nervous system. That's your adrenaline area. So if the sympathetic system is overproductive, ramped up, then the patient's going to be anxious, hypertensive, increased heart rate, increased sweating, and while all of this is happening, you're going to see decreased peristalsis because the blood's actually going to shunt everything away from the gut. So very little peristalsis, hypoactive bowel sounds, but an increase in your other vital signs. With parasympathetic stimulation, again, it's rest and digest or feed and breed. So overstimulation of the parasympathetic system would lead to lower blood pressure or low blood pressure, fatigue, increased gut activity, increased peristalsis, decreased heart rate. Okay? So make sure you go back and you review all of your physical assessment findings related to the central nervous system. Go back and look at all of the tests that are used to assess reflex testing, cranial nerve testing, and what those normal findings are. Things like, how to assess for level of consciousness, mental status, emotional status, motor movement, strength, balance, gait, coordination, deep tendon reflexes. I have pages 1920 through 1927 written down. I do not know if those are accurate for the 13th edition or the 12th edition. But in either case, go back and review how to do physical assessment of the central nervous system and then what your expected findings would be. Some age-related considerations for the central nervous system. Very important to identify normal signs of aging from abnormal changes. Okay? A lot of times a person's memory declines as they age, but you need to distinguish, is that just normal? A normal change to the nervous system, or is that, is there some pathology involved there? So really to start with, you've got to assess their baseline. What was their previous mental status? You've got to have something for comparison. So you've got to have an accurate baseline, assess the mental status very carefully, trying to distinguish delirium from dementia. Delirium includes confusion, hallucinations, delusions. Delirium has a very acute onset. It happens quickly, whereas dementia has a very slow progression and a slow onset. Also looking for those normal changes, life changes, loss of strength, changes in gait and posture, balance changes, slowed reaction times, decreased reflexes, changes to vision and hearing, taste, smell, tactile sensation. Those are all will lead to a risk of injury. Balance and posture and gait is related to a risk of fall. Also, decreased perception of pain and a decrease in their temperature regulation. So that's why older folks always feel cold. And then you throw in a little blood thinner on top of it, and they're really cold, but it's also because they lose the ability to regulate temperature as they age. Some of our nursing interventions, here are going to be aimed at helping them learn to adapt to vision and hearing changes. When you do teaching of an older individual, you have to take all of this into account and adapt your teaching so that if they can't see very well or can't hear you very well, that you alter your teaching appropriately. And of course you need to do it in a slow pace. You can't do quick teaching because they just can't process it as quickly. So you've really got to adapt your nursing interventions to fit whatever their age-related changes might be. Diagnostic tests that you're going to see related to neuro status, of course, the CT scan. These are the CT, PET scan, and MRI are all imaging scans, and they are used to look for adequate structure in the brain, in spinal cord, looking for abnormalities of structure, looking for masses that maybe are there that shouldn't be, or extra blood, just looking for anything that's there that should not be there. And then our dye studies include angiography, carotid flow studies. Even though non-invasive carotid flow, that would be like an ultrasound, but they can also do carotid studies where they have the patient, they'll inject some dye to try to highlight the flow. Then, of course, there's EEG, which is like an EKG, but it's for the brain. It measures brain waves and electrical activity. For patients that are going to have an EEG, it is recommended to hold all sedatives and seizure medications, because sedatives and seizure medications will obviously dampen or dull brain activity, and so you wouldn't really get an accurate reading if they're sedated. So, you know, there is a recommendation there. Of course, that's up to the physician, but you know, you wouldn't want to give a bunch of sedation before they have an EEG. EEGs are used to diagnose seizures, coma, brain death, you know, anything where electrical activity in the brain is in question. A lumbar puncture is the last one that we're going to talk about. It's used to do an analysis of CSF, looking for the presence of blood, bacteria, anything that should not be in the CSF. Okay, remember, it should be clear, colorless, has a few white cells, but should not have any bacteria or blood. So this process, if you'll refer to chart 65.5 in your book, page 1933, it goes through the process. Lumbar puncture is done with a spinal needle inserted into the lumbar subarachnoid space. So where it's an invasive procedure, so the patient has to give consent, or family has to give consent. It's typically done under moderate sedation unless the patient has significant neuro impairment, and then we would not sedate in that case. But it is invasive, so it does require informed consent. You have to verify, you have to explain the process to the patient, let them know what to expect. The patient can either be side-lying with their knees pulled up to their chest, or they can sit up and then kind of round their back out in a hunched over pattern. Whatever's most comfortable to the patient. A lot of times when we're having to do a lumbar puncture, they have a headache, and so sitting up is not a really good, comfortable position for them. So it's kind of whatever's comfortable for them. Of course, our role in this is to be there with the patient, assess them during the procedure, be supportive in nature, assess the site afterward for bleeding. It's a relatively small needle, so there shouldn't be a lot of bleeding, but you may still have to put a Band-Aid over the injection site, and then of course keep an eye on it. And then our big role is to label the specimen tubes and get them to the lab. These are not specimens that we want to put in that pneumatic tube system. This was a big ordeal to obtain, and so it's something that you want to hand carry to the lab. And of course they have to be labeled properly. Monitoring of the patient, definitely want to assess them for post-procedure headache, because we have gone into the spinal cord, into the subarachnoid space, and taken some CSF. There is a potential for them to develop a spinal headache. You're also looking for bleeding at the puncture site. I think your book talks about the patient should be prone for 2 to 3 hours after the procedure, or as directed by the doctor. Definitely encourage an increase of PO fluids unless they're contraindicated, like in renal disease or respiratory problems, you know, fluid overload. You wouldn't want to do that, but otherwise we can increase PO intake, and that will help to replenish the amount of CSF that we have to draw off. Even though we don't take out a lot, any reduction in CSF can be felt to a certain extent, so that's why the fluids are important to replace. Alright, complications of lumbar puncture, like I said, spinal headache. Most often you see that when they have to take off greater than 20 mils of CSF, and that is a reduction and the amount of CSF that's circulating. And then a lot of times what happens is because of the needle, they actually, the hole itself, the CSF just kind of leaks out of that hole. And because of that leaking, it creates a headache. Spinal headaches are very classic in that when the patient is sitting up or standing up, their head is excruciating, the pain is excruciating, and when they lay down flat, the headache gets better, if not completely goes away. So that's very characteristic for a spinal headache. It happens quite frequently in patients when we do lumbar puncture, which is also, by the way, called spinal tap. That's another term that people will refer to it as. And then also with an epidural. In labor and delivery, an epidural is not the same as lumbar puncture, but they can still get that leaking of CSF if the needle is misplaced. So they can still develop a spinal headache in some cases. So a treatment, or the treatment for spinal headache, is to do a blood patch. That's where the patient is positioned either sitting up or on their side again, and the doctor will go back into the spinal column just like they did to do the lumbar puncture, and at the same time we actually will go into the antecubital space and draw blood from the antecubital vein, usually about 10 to 20 mils of the patient's own blood, and then they will actually take that blood and inject it back into the back, and that blood creates a little patch or a clot that seals off the area where that CSF is leaking. When we do this, it's called a blood patch, the headache goes away immediately. So by the time you get done, lay the patient down for about 30 minutes to an hour just to make sure that they're doing okay. They sit up, headache is gone. It's an instant fix. Some other complications of lumbar puncture, which are very rare but can happen: hematoma, meningitis, and then brainstem herniation, which, like I said, is very rare. That CSF specimen should be clear and colorless. Anything that's pink tinged or even looks remotely pink has blood in it, and that's not okay, not normal. If it's white or cloudy, that can indicate a high level of white cells or bacteria. So the specimen is going to be sent to the lab. It's going to be tested. And anytime we take off CSF, it's always tested for different types of blood cells, either white cells or red cells, glucose, proteins, and bacteria. Okay, so we're testing CSF for a lot of different things. Okay, so now we're going to move into Chapter 66, which is assessment of neurofunction. Or neurodysfunction. Okay, sorry about that. So we're going to talk about nursing care, nursing needs of patients with various dysfunctions, early and late clinical manifestations of increased intracranial pressure. We're going to talk about how to take care of patients with increased intracranial pressure, talk about some different types of seizures, and then nursing care of a patient who has seizures. We're going to start with altered level of consciousness, because when we're talking about neurologic function and neurologic disorders, this is the most important place to start. Okay? The level of consciousness is the most important indicator of a patient's condition. Any change in level of consciousness is important. Good or bad, it's important to know about it. Of course, level of consciousness exists on a continuum that goes from normal, awake, alert, oriented, full cognition, which is known as consciousness, to coma. So the patient can fall anywhere on that continuum, from being completely alert and fully cognitive to being completely comatose. Okay? Alterations in consciousness are not a primary disorder, but they are a symptom of another problem. Okay? So when we talk about some different types or different conditions related to an altered level of consciousness, the first one we want to talk about is coma. That's unconsciousness, unarousable. The patient is unresponsive. They have reflexes. They have brainstem function. In many cases, they have reflexes and brainstem function, but they have no purposeful movement or no purposeful response to stimuli. So they might have those deep tendon reflexes. They might withdraw to pain. They might have a positive Babinski. They might still breathe independently, okay? But they are unconscious, unarousable, and unresponsive, meaning there is no purposeful response to stimuli of any kind. A second type we're going to talk about, the second disorder, is called akinetic mutism. That's where the patient is unresponsive to the environment, makes no movement or sounds at all, but sometimes will spontaneously open their eyes. That eye opening is not in relation to any stimulus. It's not purposeful. It's just a spontaneous eye opening. No voluntary movement, no interactions, no purposeful interaction with the environment at all. Third category or third disorder is called persistent vegetative state. That's where the patient has no cognitive function at all, no higher level cognitive processes, but they have definitive sleep-wake cycles. They'll be awake, eyes open, and then there'll be other times where their eyes are closed and they'll be sleeping. But there is absolutely no higher level cognition or interaction. And then the last one is called locked-in syndrome, and that is basically an inability to move or respond in any way. It's paralysis, and the patient is completely unable to move or respond except for eye movements. Okay, they're cognitively aware, and mentally they have those high-level cognitive function, so they're aware of what's happening and they can move their eyes, blink. So these would be the ones that you could say, if you understand me, blink once, and if you, once for yes and twice for no and things like that. And they can actually interact with you and answer your questions, but they cannot move. It's like complete paralysis, except for the eyes. Altered level of consciousness. We talk about things that influence level of consciousness. Some causes could be, disease processes, pathologic problems. Usually the disease processes, it's the result of dysfunction of a normal process. It can be neurologic, which would be like head injuries and CVAs. Toxicologic would be alcohol and drug induced. Okay? So if you think about it, these are reasons that a person would have an altered level of consciousness. It can be from disease processes, a head injury, a stroke. They can be over-sedated. They could be drunk. And then metabolic reasons, metabolic causes would be liver failure, renal failure, anything where there are toxins in the system that build up that cause a depressed level of consciousness. Basically, whenever there's an altered LOC, all of our normal processes are disrupted. It's the disruption of cells of the nervous system, disruption of the neurotransmitters, and these disruptions can lead to the development of cerebral edema. Okay? And that's real important. We're going to get into intracranial pressure in a little bit, and you need to understand cerebral edema, cerebral swelling. Okay? Or those disruptions can be, a lack of communication of those chemical transmissions. It can be impaired neuron movement, things like that. Okay, so it is essential to have an adequate level of consciousness. You've got to have intact anatomical structures. So if those structures are not intact, then LOC will be altered. And by structures, what I mean is the corpus callosum has to be intact so the hemispheres can talk to each other. Each lobe has to do its job. It has to function correctly, and it has to communicate with the other lobes. So, for instance, the cerebellum that controls balance and coordination has to communicate with the brainstem, and so on and so forth. Okay? Disruptions that occur, like I said, come from trauma, edema, increased pressure in the head, alterations in blood flow, which would be circulation of the brain, and alterations in CSF. Manifestations of disruptions are evident by a decreased level of consciousness, changes in the pupils. So the greater the disruption, the slower the pupillary reaction. They'll become slow, sluggish, and then they progress to fixed, and then they, which is unreactive. So that's why it is so important that we look at pupils. If your patient is awake, alert, and talking to you, then their pupillary function is probably normal. It's when they get altered, they have an altered level of consciousness, that you really need to look at the pupils and see if there's any involvement going on there. Medical management of altered LOC. Airway is always first and foremost, so obtain and maintain a patent airway. It's always your highest priority. The respiratory system comes right after airway, ABCs, airway, breathing. So respiratory support, they might need intubation, they might need to have a trach, they might need to be bagged or mechanically ventilated. So respiration, these are all airway, breathing, circulation. These are all supportive, that is involuntary responses. Circulatory support, because there might be a loss of regulation of heart rate and blood pressure, which would equal a disruption in mean pressure, mean arterial pressure, which would then alter blood flow to the vital organ systems. So it would be essential for us to support circulation, either with IV fluids or our vasopressor medications, to maintain the mean arterial pressure. Nutritional support, again, is started early. We've talked about that in the past with other areas, because you want to preserve gut function as much as possible. And then, of course, the goal is to find out what the problem is and treat it if you can, and then prevent any kind of complications that might be, pending. Assessment, just basic stuff. Assessment is vital. It is the key to identifying any neurologic change. So alertness is the level of responsiveness. You're looking for spontaneous eye opening. Okay? You want to know, does that patient open their eyes on their own? But you also have to take into consideration situations where the patient may not be able to physically open their eyes, like if their eyes are swollen shut, from trauma or something like that. You have to take into consideration that, they might be alert, they just can't open their eyes. Do they open their eyes spontaneously? Do they open to voice, tactile stimulation such as touch, pain, deep pain, or noxious stimuli, or do they not open their eyes at all? So alertness has to do with eye opening, very important. Motor function, is it voluntary? Are they moving all four extremities on their own, equally, independently? Is the movement purposeful? You know, are they able to control their motor function, or is one side weaker than the other? Are they withdrawing only to pain, to deep pain? Do you see posturing? Is there no movement at all? Then you definitely want to know if you're noticing one side is weaker than the other. You then need to evaluate, is that a new thing? Is that a new change? Or is that a pre-existing disability? Is one side just weaker than the other, or is one side completely flaccid? How long has it been that way? So that's that grip strength, okay? When you're really, what we're talking about here is a basic neuro assessment, alertness, and then motor function, their ability to move and do grip strength. Also want to assess respiratory rate and pattern, work of breathing, looking for things like Cheyne-Stokes respirations, which are called neuro respirations or neuro respiratory rate. Signs of hyperventilation, because Cheyne-Stokes will do that. They get to breathing really fast. Looking at pupils, equal, round, reactive to light, accommodation. Checking for eye signs, which are those abnormalities that I mentioned earlier in the semester. We talked briefly about the doll's eyes sign, and that would be where you hold the patient's eyelids open, and you turn the head to the right or left very quickly. It doesn't matter. You just turn it to one side or the other. The eyes move in the opposite direction if the brainstem is intact. So that's known as a positive doll's eyes reflex. If the eyes move in the same direction that the head does when you turn it, then that means the brainstem is not intact. So that would be a negative doll's eyes, and that's a sign of severe brainstem injury. So again, you would hold the eyelids open. So there's clue number one. If you have a patient and you have to hold their eyelids open, well, that's a sign that they are not alert. They've got an altered level of consciousness. Something's not right. But you hold their eyelids open, and assuming they don't have any neck injury or spinal cord injury, it's okay for you to turn the head. You can turn it very quickly to the right or to the left, and the eyes should move in the opposite direction. Okay? If the brainstem is intact, the eyes will move the opposite direction from the way the head turns. Okay? That's a positive doll's eyes. And then the opposite of that would mean that the brainstem is not intact, and that's definitely not a good thing. Another eye sign is called a corneal reflex test. Basically, that's where we take a Q-tip or some kind of cotton-tipped applicator and touch the cornea with just a wisp of that cotton. And, you know, if I come at your eyeball with anything, you should be blinking and pushing me away. But in these patients with altered LOC, if we touch the cornea with a little wisp of cotton, because, you know, we don't want to scratch their eyeball, but if we touch it with a wisp of cotton, they should blink if their brainstem is intact. But if it is not irritating to them, if they don't blink in any way, then they have severe brainstem damage. Another assessment finding, another thing that we're going to be looking for are reflexes. Swallowing reflex is one of the easiest to assess whether or not they're swallowing. Even if they're intubated, you can still tell if they're trying to swallow. And then assessing the deep tendon reflexes, that Babinski reflex, which is only normal in newborns. Sometimes in severe brain injury, you will see the patient develop a Babinski again. So a positive Babinski in an adult is never a good thing. Okay? So go back and review those deep tendon reflexes. Refer to Table 66-1 for assessment of the unconscious patient and all of those things that you should really be looking for at normal findings, abnormal findings, and what they mean. Posturing. Talk about posturing briefly. There are two different types of movement that can be elicited from painful stimulation. So when we are assessing our patient and we're trying to find out, do they respond, they're not spontaneously responding to us, and we're seeing movement when we touch them or movement when we elicit pain, then we need to know what kind of movement are we seeing, okay? And that's called posturing. So there's two types of posturing, decorticate and decerebrate. I always remember the difference in the two because decorticate, core, C-O-R, means pretty much everything kind of curls in or turns in toward the middle or the core of the body. So in decorticate posturing, the patient's arms, they will be stiff, clenched fists, legs are going to straighten. They'll be kind of straightened out, but the arms are going to kind of turn in or curl in. The wrist and the fingers are going to kind of go inward toward the center or midline, the core of the body. It's a sign of damage to those nerve pathways between the brain and the spinal cord. It's not a good sign, but it's not as serious as decerebrate. Okay, so if you've got to have one, if you've got to have a type of posturing, you want it to be decorticate because it's not as bad. And this can happen, a lot of times you'll see posturing in general if you move the patient, if you have to scoot them up in the bed, if you turn them, if you suction them, if, sometimes it's just light touch. It doesn't have to take a lot of stimulation. But it's a sign that there's brain damage, and it's irritating. It's considered an irritant or painful, even though it's not painful like you would think pain. It's something that's irritating to the patient, and so it causes them to have this abnormal movement. Okay, so decorticate just means that they're kind of turned in, arms bent in toward the body, kind of toward the core, toward the chest. Okay, and you can see posturing on one or both sides of the body. It's not always both sides of the body. I've seen cases where a patient had a previous CVA from years before, and one side, let's say the right side, was completely flaccid. And then they had another stroke later, and they developed altered level of consciousness, and we could see posturing on the left side. The right side's still flaccid, completely flaccid, but the left side will posture, or vice versa. And then I have seen cases of patients who were, had no physical impairment of any kind, and then they had a stroke, a massive stroke, and they were posturing on both sides, both arms, both legs. So it can be one or both. Decerebrate posturing, again, is another type of movement that's elicited from irritating or painful stimuli. This is a posture where the arms and legs are kind of held straight out, and it says the head and the neck arch backwards. What I've seen more in decerebrate is that the arms are kind of straight down by the side and the fists roll out or kind of curl outward. There's the next slide, I think, has a picture of it. And I'm also going to give y'all some handouts, too, about all of this. But it's where the wrists kind of turn outward, okay? Instead of the arms being drawn in toward the core of the body in decorticate, this is where it kind of turns in an outward way. And this is a sign of very severe brain injury, okay? So it is worse than decorticate. So here's the pictures I was talking about. As you can see here in decorticate, those arms are kind of drawn in to the core. And then over here with decerebrate, you see how the wrist is turned outward, okay? There are other signs in the legs and in the neck and back, but really it's the arms that you can really tell the most difference in. Okay, interventions, nursing interventions, when we're talking about altered level of consciousness. Our major nursing goals, of course, are to compensate for the patient's loss of protective reflexes. They cannot protect themselves. They have an altered level of consciousness. So our job is to protect them, to keep them safe. So we end up, we're doing all patient care, total patient care. We've got to do thorough assessment for airway, breathing, respiratory status, work of breathing, lung sounds, positioning, removal of secretions, airway obstruction, monitoring for obstruction, keeping them suctioned. In these patients with an altered level of consciousness, the head of bed should always be at least 30 degrees because you want to promote drainage and we don't want them to aspirate. Suctioning, oral hygiene, CPT, anything that has to do with airway obstruction, we've got to keep their airway clear, okay? Side rails, definitely want side rails up, padded if need be, if there's a problem or a history of seizure. We have to be aware of invasive lines. Again, these people have an altered mental status, so they might very well have an arterial line or central line. So we've got to be very cognizant of our invasive lines and other things like dressings and restraints, anything that can be considered an environmental irritant in a comatose patient or somebody with an altered mental status. And I don't mean confused altered, I mean comatose. They cannot, protect themselves. We have to be their protection. So we have to assess for things like swelling. A lot of times if they have an altered mental status or they're comatose, then we have problems with third spacing. And so the armband, as the patient's arm swells, the armband gets too tight and it can actually cut the skin or lead to breakdown or decreased blood flow. If they've got rings on or jewelry, a lot of times, we need to get that jewelry off before so much swelling occurs and it, causes a circulation problem. We've got to be very diligent about assessing for skin breakdown, keeping them turned because they do not have any protective reflexes. They do not, they don't know that their butt hurts because they've been laying on it for so long. So we've got to be diligent about turning, keeping our sheets straight, not wrinkled, changing wet bed pads when they get sweaty. Those are all things that are considered environmental irritants. Especially if we have brainstem involvement, they're going to lose their ability to regulate temperature, so it's very likely that they will be very sweaty. So keeping them dry so they don't have skin breakdown. We have to be diligent about maintaining privacy and dignity, even though the patient is not cognitively aware. And, we have to advocate and maintain their dignity and privacy. Okay, so that means that we never speak negatively about a patient's condition in front of the patient, because it is proven that hearing is the last sense to go. Even if the patient can't respond, we don't know to what degree they can hear. So you never speak negatively or disrespectfully in front of the patient, ever. And I personally think that it is very appropriate to speak to the patients, even if they are unresponsive or comatose. Talking to them, I think, is important. Hearing is the last sense to go. So it's important to be realistic, but don't be negative. Fluid and nutritional balance, oral care, these are all important nursing interventions. We've got to maintain hydration, assessing, for signs of hydration. Of course, that includes our urine output, INO balance, looking at all the electrolytes and lab values, assessment for turgor, things like that. Keeping them hydrated, administering fluids, blood if necessary. We definitely want to avoid giving fluids and things too quickly because we don't want to fluid overload them. And we definitely don't want to increase intracranial pressure if they're having problems with that. Nutritionally, oral is always best. That should always be our first choice. You would never feed a patient, never give them oral intake if you are not sure about their ability to swallow. It is perfectly within your scope of practice to check a gag reflex on a patient. If you know they have neurologic impairment, you're not sure, you can always get a tongue depressor or a spoon or something and check to see if they have a gag reflex. If it's questionable and you're just not sure, it is perfectly within your scope of practice to hold that patient in PO and notify the doctor. Okay? You don't have to have a written physician order to make a patient NPO if you feel like they cannot swallow. Okay? But you have to notify the physician. You have to document it and notify the physician so that they can order a swallow study. Okay? So the moral of that story is don't go try to shove pills down their throat if you're not sure they can swallow. Okay? And then, of course, TPN or PPN, if they can't swallow, then we would go to parenteral nutrition, and then eventually they would probably, if they don't think the swallow reflex is ever going to come back or not going to be sufficient, then they would move to peg tube placement. Oral care is essential in an unconscious patient or a comatose patient because we want to prevent pneumonia. Okay? VAP stands for ventilator-acquired pneumonia, and that's assuming that the patient is on a ventilator. In some cases, your comatose patient may not be intubated, but oral care is still essential because the mouth is nasty, and that is the number one way that people end up with pneumonia because they aspirate all that junk. So keeping the mouth clean, keeping the lips and the tongue moistened because they will dry out. Remember, the patient does not have any protective reflexes, so they don't lick their lips, and obviously we're not giving them oral intake, so it's not unusual for the tongue to dry out. It can crack, and the drier it gets, it'll swell up. So it's important to keep it moist and inside the mouth. The more it swells, the more it will actually protrude from the mouth, and eventually it can actually begin to necrose. So it's very important that we do good oral care. Okay? Skin and joint issues, turning the patient, assessing for breakdown, watching bony prominences, avoid shear and friction, making sure that we're not dragging them across the sheet, across the bed, padding, body alignment, passive range of motion, splinting, using boots and trochanter rolls in the hands. Specialty beds are very applicable here. Just all the things that you know to do to prevent skin breakdown, keep the joints from becoming contracted, proper body alignment. This is where you'd want to use those, putting the patient even in just tennis shoes or some kind of heel support or boot, foot support to keep them from developing foot drop. Trochanter rolls, like I said, for the hands. And then as far as the cornea goes, they have that no protective reflex. They can't blink. So a lot of times we're going to have to clean the eyes, moisten the eyes with artificial tears, saline, moistened cotton balls, a lot of, maybe covering the eyes, putting lubricant in the eyes and closing them with an eye patch. But you have to be real careful about using eye patches because if you don't lubricate them and you close the eye and you don't lubricate it, then the eye patch could actually stick. Okay, the eye could actually open underneath and the patch would stick to the cornea. So it's very important that you lubricate the eyes with water-soluble lubricant and then either keep them closed or tape them closed or, just some measures to protect the cornea. I know it sounds kind of strange, but there are a lot of patients with altered level of consciousness. You close their eyes and their eyes won't stay closed. You close the lids and then they come right back open. And so those are the ones that you really have to make sure and protect the cornea from drying out. Body temperature is another issue. They often lose their ability to regulate temperature. So they can get what we call as a neuro fever. They can develop fever just from an increase in metabolic and oxygen demand. If they're sick or they're septic or whatever is going on. But then they also, because they don't have that ability to regulate temperature like a normal person does, they can get a neuro temp that can get up like 105, 103, 104, 105. When you get up 105, 106, that's when it starts to begin to damage the brainstem. So it's very important in an unconscious patient with a fever that we keep close eye on it and then do things to lower that fever and reduce that metabolic demand as much as possible. So keeping the room cool, turn the thermostat down, taking the covers off the patient, maybe just covering them with a sheet, Tylenol, ibuprofen sometimes. It depends on the doctor. The book talks about nothing but Tylenol. A cooling blanket, a cool sponge bath, cool rag at the neck, over the head, fans, using a tympanic or a rectal temperature because they are the most accurate. Reducing energy expenditures, so you want to make sure that the patient doesn't shiver. You want them to cool off, but you don't want them to start to shiver because then that actually increases the metabolic demand more. And then, of course, ruling out infection. You're looking for sepsis, pneumonia, things like that. Persistently high temperatures that, are very difficult to get them to come down, even with Tylenol and other measures, can be brainstem related, brainstem dysfunction, and that's that true neurotemp. Bowel and bladder function. Of course, these people, they're unconscious, so they're going to have a Foley, but, they can't tell you when they're wet and stuff like that. So if they don't have a Foley, it's essential for you to assess to make sure that they are not retaining urine. So you would need to do a bladder scan, palpate, make sure that they're not distended. If they're incontinent, keeping them clean. We may need to cath them or do in and out catheters. It just depends on the situation, but we're monitoring for UTI if they do have a catheter, keeping them clean, hygiene, all that. And then as far as bowel function, bowel sounds, distension, looking for signs of constipation, if they are incontinent of bowel, keeping them clean. In a lot of these patients, they will put them on a bowel training program, stool softeners and suppositories or enemas. The problem here is that they're immobile and they have decreased nutrition and decreased hydration. And a lot of times they have an increase in medication intake, so that does all promote constipation. So you have to really implement all of those nursing interventions related to prevention of constipation, okay? And then skincare if they're incontinent. So, being diligent about that if they are incontinent of bowel and bladder. And then, too, a lot of these patients, you have to consider they have invasive lines. So if they have a femoral site, a femoral IV site of any kind, and you're having trouble with incontinence, you have to be diligent about keeping that femoral site clean so that they don't develop a central line infection. Sensory stimulation and communication. Once we get to the point where elevated intracranial pressure is not an issue, then we need to really be stimulating this patient. Talk to them, touch them, encourage family to do the same. We really try to maintain a very normal day and night pattern, so lights on, windows, sunlight in during the daytime, and then lights off, stimulus off at night to help them keep that normal pattern. Reorientation, even if they're not awake, coming in the morning and talking to them and telling them, hey, today's Tuesday, October 20th, my name's Amy, I'm going to be taking care of you today, it's real pretty outside, the sun's shining, it's about 8 o'clock in the morning, just talking to them, trying to keep them oriented. Remember, hearing is the last to go, so even though they may not remember any of it, it's still, there is some research that supports talking to them and, keeping physical touch and communication intact, okay? Once they really begin to wake up and they begin to come back to a sense of orientation and reality, initially as they're waking up, they might be agitated because they just, they're confused. They don't know where they are. They don't know what's going on. So they can actually, as they're waking up, they can be very agitated. And this is the point where you would really want to minimize stimulation. You don't want to overstimulate them. They're going to wake up and have a sense of lost time. They're the last thing they remember is going to be at whatever point they lost consciousness. So however long it's been, if it's been days or weeks or months that they have been unconscious, then they're going to have to deal with that whole issue of losing that amount of time. So there's a lot of psychosocial support that goes in to that. Dealing with the family, allowing them to talk about their feelings and it's just tough. It's tough to watch your family member be comatose and as they're waking up, there's a lot of family dynamic and psychosocial coping things that go on there. So a lot of reinforcement and encouragement and education and support for the family as well as the patient. Finding those support services might be a support group or encouraging the family to get counseling or, just coping with this whole process, okay? It's very important. Okay, so we're going to talk about increased intracranial pressure next. Get a little drink of water. All right. So when we talk about increased intracranial pressure, some basic things. First of all, your brain, all the blood, and the CSF, all three of those things, live inside your skull. And your skull is hard. It's a fixed vault, meaning if you sprain your ankle, that's soft tissue. There's soft tissue injury. It's going to swell up. Your ankle is going to swell. It has room to grow. Well, your brain is tissue also. So if there's damage to that tissue and it swells because of inflammation, it can only swell up so much until it hits the bone and it can't go anywhere else. Okay, that's what I mean by a fixed vault. So just remember that when we're talking about increased intracranial pressure, there is only so much room inside the head, inside the skull, for things to grow, so to speak, or to have an excess. So we have brain tissue, blood volume, and CSF volume. And there are normal amounts of all three of those. An increase in any one of those three things inside the skull causes a disruption in the normal pressure inside the head. Okay? So it can be brain tissue that swells up. It can be an excess of blood from too much blood flow into the brain. Or it could be bleeding into the brain where, blood where it shouldn't be. Or it can be an excess of CSF. An increase in any of those things, a change in any one of those will change the volume in the other. Meaning that if brain tissue swells, the body will compensate by reducing blood flow and reducing CSF. If there is an increase in the amount of blood in the body, or in the brain, the body will compensate by reducing CSF, okay? So, and reducing pressure in the brain. So it's a compensatory mechanism, okay? That's the Monroe-Kelly hypothesis. Then an increase in any one area will cause a change in the volume of the others. Our normal intracranial pressure is 0 to 10, I think is what your book says is normal. And then 15 is the upper limit of acceptable. So really we're talking about 0 to 20, okay? If we get up above 15, we've got a problem. If we get above 20, we've got just a really super big problem, okay? So the body maintains this normal amount of pressure by compensating or shifting or displacing one of the three components, okay? So usually it's CSF. So if we have too much pressure inside the head, our ICP, intracranial pressure, gets up above, 10 or so, then it triggers this compensatory mechanism to either reduce production of CSF and or reduce blood flow to the brain, okay? Too much pressure, we don't need as much blood, we don't need as much CSF, so the body shuts it down, reduces it. The problem with that is if we don't have as much blood flow to the brain, if we have reduced blood flow, then we have reduced perfusion. And if we have reduced perfusion to the brain, then it's not getting oxygen like it needs, and so it can develop ischemia. All right? If there is ischemia in the brain, then yes, it can lead to tissue death, but before it causes tissue death, it actually causes ischemic, any area that doesn't have good blood flow is considered ischemic. Ischemic areas or ischemia will lead to cellular changes, a lot of physiologic processes that I don't really care about specifically, but cellular changes that actually lead to further edema. So then that further edema increases the pressure, which in turn causes a reduction in CSF and a reduction in blood flow to the brain, which reduces perfusion to the brain. Reduced perfusion causes ischemia, and ischemia in turn leads to those cellular changes that leads to more edema, which increases the pressure and starts the process all over again. Okay, so it is a vicious cycle. Eventually, ischemia leads to cell death and tissue death, and there comes a point where the pressure is so great inside the head. The body has already tried to reduce the pressure by limiting blood flow and limiting CSF, but there comes a point when the pressure gets so high that the actual brain tissue will be pushed or shifted, and the only opening out of the cranium is through the brainstem at the foramen magnum. So eventually the brain tissues will shift, and they'll actually herniate through the foramen down into the brainstem. Okay, so that's why it is so important that that we keep track of intracranial pressure. And once we get up around 15, then they really start to consider, what do we need to do to lower, methods to lower the pressure. How can we stop this elevating pressure? And then anything greater than 20, an ICP greater than 20, has to be treated, or there's going to be herniation. Okay, so this is a picture of kind of the normal brain structures. To me, it always looks like a butterfly. And some of you, I have talked about this in clinical, but these are the ventricles here. And these are areas where there's normally a small amount of CSF, okay, lubrication. And it just looks like a little butterfly and a real happy smiley face, okay? And you can see, and I'm not going to ask you, what each of these things are called, so don't waste your time learning frontal horns of the lateral ventricle. I don't care about that. I just want you to know that these green things right here are ventricles, and there's two of them. And then this little midline ventricle right here, it should be midline, okay? And then the little smiley face, it should be, symmetric. Both sides should be just like a little smiley face. And then this midline right here and down here, you can just use these as a reference. Okay? We are not radiologists. It is not our responsibility to be able to read a CT scan or an MRI. But I'm showing you this because I want you to know what normal looks like, so that when you see abnormal, you can recognize it. So remember those nice little green butterflies that we were looking at a minute ago? Well, here's your butterfly. Here's your ventricle. And it's okay that it's bigger. This is just the level of where the scan is in a different place than the other picture. But here's half of our butterfly. And you can see this other half is way narrow. And the reason for that is all of this white stuff right here. Okay? If we come over here and you look, here's the ventricle. And here's a ventricle, but this ventricle is mashed closed. And that's because all of this off-white stuff is blood. This is a intracranial or a subdural hematoma. And all of this blood has collected inside the skull, and it has pushed all of this brain tissue right here that way. And so really what's happened is all this brain tissue has gone over here and collapsed this ventricle. Okay? So that's an example of what we call an intracranial shift. That means the tissues and the ventricles have shifted beyond midline. You see this midline and it's kind of curved like, okay? It's an intracranial shift. Now sometimes there will be what's called a midline shift, and that would be where this whole midline structure is moved all the way over to the other side. Okay, it's like a complete deviation from midline. That would be like a midline shift. Okay, either way, this is not good. Okay, so cerebral edema. We talked about that whole process of increasing pressure that leads to cellular changes, which leads to edema, which increases the pressure and leads to ischemia, and on and on and on. Cerebral edema is an abnormal accumulation of the fluid, abnormal intracellular, extracellular brain tissue, or both. And again, as the tissues swell, intracranial pressure increases. Body attempts to compensate. The brain attempts to compensate by reducing blood flow, reducing CSF production. It's a balance. This is a fine balance between too much blood flow and not enough. Okay? This auto-regulatory process that is going on. Auto-regulation means that the brain has the ability to alter the diameter of blood vessels to maintain adequate blood flow. Okay? So if blood flow is reduced, then the natural response of the body is to dilate, to vasodilate, and increase blood flow to the brain. Okay? Because remember, the brain likes to have oxygen. And it's a fine balance, like I said. CO2 is a very key player in this whole process. CO2 is a very potent vasodilator. So if the body senses not enough oxygen, it's going to increase the amount of CO2, which causes vasodilation, increases blood flow, and will increase intracranial pressure. Okay? Now, under normal circumstances, not in head injury, I'm not talking about a head injury patient, but I'm just talking about you and me, every day, rocking on through life. When the body senses that we don't have enough blood flow to the brain, you know, it's that auto-regulatory process. For some reason, we don't have enough blood flow. It stimulates an increase in CO2. Well, how do you increase CO2? You breathe less. You have to hold on to it, right? So the body slows respirations, causes you to retain CO2, which in turn leads to vasodilation, increases blood flow, improves blood flow to the head. Okay? That is the normal auto-regulatory process. If we have too much blood flow, the pressure in the head is too much under normal circumstances. Just, you know, for whatever reason, the pressure elevates slightly. The body's auto-regulatory mechanism is to blow off CO2. So we want to get rid of it. We want to, and it's through breathing. It's a ventilatory process. You'll breathe faster, blow off more CO2, which leads to vasoconstriction and reduced blood flow, and that lowers the intracranial pressure. So in a patient with brain injury, they lose some of this autoregulatory process. Okay, I mean, the body still tries to maintain it, but it's much harder for the body to do. So sometimes we have to help it out. And one of the ways that we can lower intracranial pressure is by blowing off CO2, getting rid of it. We want to lower our CO2 level on the patient, and we do that by hyperventilating them. So one of the first things that you will do in a patient with increased intracranial pressure is to bag them and probably intubate them. And that way you can hyperventilate them and you can drop their CO2 levels down really low, and that leads to vasoconstriction, which will help reduce intracranial pressure. When we're talking about intracranial pressure and perfusion pressure, you need to understand that cerebral perfusion pressure is pretty much equal to your mean arterial pressure minus ICP. Now, under normal circumstances, you are not going to be able to calculate this in your patient. You have to have an ICP monitor to be able to calculate cerebral perfusion, okay? So, before you get all freaked out about test questions, I would have to give you the mean and the ICP, or you couldn't calculate it. So I just want you to know that normal cerebral perfusion pressure is 70 to 100, and that you've got to have at least 70 to 80 to have adequate brain perfusion. Okay? The brain can maintain a very steady state with pressures between 50 to 150 as long as the ICP is less than 40. Okay? The brain can maintain and be just fine. As ICP increases, all of that autoregulatory process that I was talking about with the CO2 and all of that stuff begins to fail as ICP increases. And so ultimately cerebral perfusion pressures get jacked up. Okay? So normal CCP, whatever. I got my mnemonics wrong. Cerebral perfusion pressure, which is CPP, not CCP. Cerebral perfusion pressure, normal is 70 to 100. 70 to 80 is adequate. Less than 50 results in permanent neurologic damage. Okay? So we got to keep CPP at greater than 50 at all cost. Okay, now I'm going to tell you, if we're talking about cerebral perfusion pressure, the kidneys are already gone. I can tell you. If we're talking about maintaining perfusion to the brain, then we already have some major organ systems at risk of being without perfusion. Okay, Cushing's response. So the next thing I want to talk about, it's a phenomenon that we see. It's a late sign of increased intracranial pressure. So it's a clinical situation or a picture that we're going to see with significantly decreased cerebral blood flow. So basically, increased intracranial pressure leads to decreased cerebral blood flow or cerebral ischemia. Okay? So increased intracranial pressure leads to cerebral ischemia, and that can result in Cushing's response. So what happens is the cerebral ischemia triggers an increase in blood pressure, and that is an attempt by the body to overcome the elevated pressures inside the head and maintain blood flow. Okay? So increased intracranial pressure leads to cerebral ischemia, which then triggers an increase in systolic blood pressure. And so as this process begins, we see elevated systolic pressures, a widened pulse pressure, and decreasing heart rate. And this is a bad sign. In a patient that has increased intracranial pressure, when you see these things, elevated systolic blood pressures, widening pulse pressure, which means dropping diastolic, and a decreasing heart rate, that's a very ominous late sign means that we need to do something quick, okay? Requires immediate intervention. It can be reversed. We can prevent permanent damage, but we've got to get on it, okay? Cushing's triad is the next stage in this phenomenon where all of our autoregulatory mechanisms stop. They just completely fail, and the patient begins to deteriorate or decompensate, okay? So that cerebral ischemia leads to cerebral infarction and cerebral tissue death. So signs of Cushing's triad, it's a significant change in mental status. These are the ones that, they've been maybe not oriented and necessarily alert, but they have been moving and interactive, and now they are nothing. There's no interaction. So it's a significant change in mental status. And then the classic triad is bradycardia, hypertension, and bradypnea. Okay? So it's a change in respiratory pattern. Okay? This is indicative of brainstem herniation. It's a very grave sign, impending brain death. Treatment must be implemented to stop this increased pressure, or the patient's not going to live. Okay? It's just not, this is a bad deal. So there is a difference between Cushing's response and Cushing's triad. So Cushing's response is the initial part, and then as it progresses, it leads to Cushing's triad, where you get bradycardia, hypertension, and bradypnea. Okay, so this is a picture of brainstem herniation. So the yellow line is the level of the foramen. So this is kind of the level of, that's where that opening is, and there shouldn't be any brain tissue below this point. But as you can see in, let me get a little pointer here. Oops. So all of this right here is brain tissue. Okay? And none of it should be down here. It should all be up here. Alright? There shouldn't be anything below this little yellow line right here. There shouldn't be anything below that line. All of this tissue should be up here. So that's just an example of how the brain, the pressure inside the head has caused a shift of the structures, and it's path of least resistance. It's going to find the place with the least amount of resistance or pressure, and it's going to go through it. So that's an example of brainstem herniation. That's a bad sign. All right, so manifestations of increased intracranial pressure. Of course, look at your chart on chart 66-2 on page 1952. But these are clinical signs or manifestations. Okay, so our earliest sign of increasing ICP is a change in level of consciousness. That's why I'm telling you that thorough and accurate assessment of level of consciousness is essential. Other signs can be speech changes, a slowing of responses, slowed movement, delayed reflexes, anything like that. But our earliest sign is a change in level of consciousness. Any change, any slight subtle difference that you see in a patient with a head injury or any kind of neuro problem, any change is a big deal. restlessness, confusion, headache, more sleepy than usual, increasing respirations, changes in movement, pupil changes, anything like that that is different than what they were before, a change from their baseline, is clinically significant and needs to be reported. As your ICP increases, mental status will decline, and they will move from awake and oriented and cooperative to confused, anxious, stuporous, and then they go to painful response only, and then they go comatose. Okay? You're going to see posturing. They will eventually become flaccid as the pressure increases. Posturing will be evident to a point, and then as the pressure becomes so great, they just become flaccid. In a profound coma, the pupils will be fixed and dilated. They will have no respiratory effort, spontaneous respiratory effort. And so, of course, it leads to death. So at this point, in patients with very elevated ICP, we have to do not just treatment of intracranial pressure, but we've got to protect their airway. We've got to, they need to be intubated. We're having to do blood pressure control. There's a lot of aspects here that have to be implemented. Complications of increased ICP, of course, brainstem herniation. We talked about that already. Diabetes insipidus. Go back and brush up on diabetes insipidus. It's the result of a decrease in ADH, antidiuretic hormone. We don't have enough of it. We don't have enough of the no-pee hormone, so the patient just pees and pees and pees. Excessive urine output, electrolytes get all messed up. So decreased urine osmolality, increased serum osmolality. Go back and brush up on what all that means. Increase in serum osmolality basically means they're hemoconcentrated. Okay, treatments are going to be aimed at fluid and electrolyte replacement, and then DDAVP is our medication, which is vasopressin. So diabetes insipidus is one complication that can result, and it's not unusual to see patients with head injuries that develop diabetes insipidus. They just pee and pee and pee and pee. It's like crazy. So you have to be very cognizant of dehydration. Another complication is SIADH, and that is the opposite of diabetes insipidus, where they have too much ADH, and so they don't pee at all. Okay, and so these patients will get overloaded. They'll have fluid overload, no urine output, very diluted or hemodiluted serum, so their blood volume becomes very hemodiluted, and so with that comes the lowered electrolyte levels because of dilution. It's a dilutional or a relative problem. Of course, our treatment here is going to be aimed at fluid restrictions. We definitely don't want to give them any more excess fluid. And then this is one of the only times that we would give a hypertonic at 3% solution. Not always, but we're not prescribers, and we're definitely not doctors, and so don't worry about that. But it's fluid restriction here in all of your interventions that are aimed at fluid restriction. And so you could see that if your patient had existing COPD, how bad this could be for them. Or is in a case with diabetes insipidus, if we had elevated ICP and it led to diabetes insipidus and your patient had renal dysfunction, you could see how bad that could be. So just think about these two different disease processes and your nursing interventions that are related to each of them in terms of keeping your patients safe. All right, medical management related to increased ICP. Our goal here is to maintain the mean arterial pressure to keep adequate perfusion to the brain. Okay, we've been talking about that all semester long, that we've got to have an adequate mean arterial pressure, adequate cardiac output to maintain perfusion to vital organs. And it's no different with the brain. As our cerebral perfusion pressure decreases, that's a very strong indication that cardiac output is also decreasing. Okay, so our goal is to maintain perfusion. Invasive monitoring with an ICP monitor, making sure that there's adequate cerebral oxygenation, which means intubation of the patient, monitoring O2 sats, making sure that they are oxygenated well, because remember, if we don't have enough oxygen, it creates ischemia, and ischemia leads to edema, and edema leads to increased intracranial pressure. So we want to stop that cycle. We want to institute measures to decrease cerebral edema, and that's going to be use of things like osmotic diuretics. Those are the very potent pullers. Mannitol is our drug of choice. Your patient's going to need a Foley catheter because they are going to be putting out so much. You've got to keep track of it. Other measures to maintain cerebral perfusion are done by manipulating cardiac output. So we're going to be using drugs like inotropes, just our various vasopressors to kind of manipulate and balance the cardiac output and maintain the mean in an attempt to maintain perfusion pressure. Also going to be doing measures to reduce CSF and intracranial blood volume, which might be a CSF drain. That's way advanced stuff, so don't worry about that. But, you know, osmotic diuretics, it's going to pull, shift the fluid, osmotic fluid shifting, and in some cases they will put in a CSF drain to try to drain off some of that fluid, but that's in the very specialized neuro units. Okay, you won't ever probably see that. You won't ever, well, I say you won't ever see it at Bossier, and we had 2 this semester, but anyway. Fever control, that's another key factor. Remember the neurotemp? It's a loss of that autoregulatory function, and so you can give them Tylenol all day long, and when they get to this point, it really won't work. It's not going to control their fever. So really the goal here is cooling measures, but cooling without shivering, okay? Maintaining oxygenation, maintaining metabolic demands, so sedation. Barbiturates and propofol are the drugs of choice. We want them sedated. Support with oxygen, continuous pulse ox, we're checking ABGs. Definitely want to control increased fever because we don't want to elevate the metabolic demand, because of fever, but we also don't want them to cool too much so that they shiver. These patients are going to be hyperoxygenated. If they're intubated, we're going to be keeping them hyperoxygenated to blow off all of that excess CO2. That helps to vasoconstrict and lower ICP. Neuro checks very frequently. Typically, in a situation like this, you're doing Q1 hour, maybe Q2 hour neuro checks. And then, if the patient is sedated, then you need to look at how do you do an accurate neuro check on a patient who is sedated. And this gets into what we call sedation vacation, where you temporarily suspend the sedation. till you can see a true baseline neuro status. Now you have to use your judgment in that when you turn off the sedation, if the patient wakes up and becomes combative or agitated, then that is not good. That increases their metabolic demand. That's going to increase their intracranial pressure. So you got to immediately resedate, okay, because you want to keep them calm. But it's a balance. You've got to know their baseline neurostatus, but you don't want to increase intracranial pressure. So, you know, balancing out that sedation is very important. Nursing interventions related to all of this: assessment, 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 assessment. All of your assessment findings, all of your observations are always in reference to your patient's baseline. Any change has to be reported, and it's essential that you not only report but document, okay? Got to have patent airway, maintain patent airway with suction, but you have to understand suctioning increases intracranial pressure, so you have to do it cautiously, gently, with great care. And then if the patient is not intubated already, then you anticipate, as the ICP increases, you anticipate intubation. You have to assess for adequate breathing pattern, making sure that they have adequate, if they're not intubated, they've got adequate rate, depth. You know, looking for Shane Stokes, you're monitoring for hyperventilation and periods of apnea. Many times with that Shane Stokes pattern, they will breathe very heavily initially, and then they'll taper off, and then they'll just be apneic for a little bit. So you have to do diligent assessment in that regard, monitoring for apnea spells. If they're intubated and you're hyperventilating, then you want to keep an eye on the CO2. Typically, they'll use a CO2 monitor, and you're looking to keep that CO2 less than 30. If you remember, normal CO2 is 35 to 45, but we want to keep that CO2 level below 30 with hyperventilation, because that helps to promote cerebral vasoconstriction and lower ICP. Measures to optimize cerebral perfusion would be your positioning. If you'll refer to table 66.2, it talks about some of these. But positioning, keeping the head of the bed elevated 30 degrees. You want the head midline, no turning the head or flexing the head, no hyperextension of the neck, no hip flexion. Definitely don't want them to bear down, no Valsalva maneuvers, no coughing, sneezing. Cough and sneeze need to be done with the mouth open if they're awake enough to do that. Use of stool softeners if the patient is alert enough. Like I said, you don't want them bearing down. If they're intubated, you know, pre-oxygenation before suctioning. Limit your suctioning, no more than 15 seconds. Definitely don't want to use high-level PEEP in these patients, because that will increase intracranial pressure. Keep them calm and quiet. Limiting stimulation, lights off, no visitors or very, very limited visitors. You really don't want to use sedation at all. Sedation is not ideal in these patients, but in some cases it is needed to help them stay calm. And keeping them calm is the key to keeping the intracranial pressure down. Keeping their fluid balance negative. We don't want them overloaded. Definitely want to keep them more on the dry side. Loop diuretics, the osmotic diuretics, or both. Hourly outputs, monitoring very closely, because we're keeping them dry, we're keeping them dehydrated. You've got to watch for hypotension and then other issues related to dehydration. Strict infection prevention. especially if they have an ICP monitor. You want strict aseptic technique, and then a frequent assessment of that fluid to make sure that there's no infection developing related to that ICP monitor or a CSF drain if they have one. Intracranial surgery would be your intervention here. Craniotomy is just going to be, an opening in the skull where we go in surgically and create an opening to relieve the pressure. We can use a craniotomy to remove a tumor, relieve the pressure of an elevated ICP, evacuate blood clots, control bleeding, just hole in the head. Craniectomy is where we actually go in and remove a piece of the skull. That should be skull, not skill, but skull. You will see this done a lot of times in patients with head trauma, brain injury. They go in and they will remove a piece of the skull, and they will actually save that piece of skull. They can implant it. A lot of times they will implant it into the patient's abdomen, and they kind of the patient becomes its own, not incubator, but that piece of skull just lives in the abdomen. It's fine until such time as it can be replaced in the skull. And so that I've seen that done. Or they can remove a piece of the skull, craniectomy, and then eventually they have to have a cranioplasty where we put a piece of plastic or a metal plate or something over that opening or that hole. And then another type of intracranial surgery is called a burr hole. That's where we just literally drill a hole into the skull to relieve pressure, or sometimes they'll use it for exploration, but most of the time it's just to relieve pressure related to increased intracranial pressure, so that the ventricles, if they've shifted or if there's a problem, that we can just relieve that pressure. We can aspirate any kind of hematoma or clot or anything that's going on in there. Our preoperative care is going to include testing, CTs, MRI, Doppler flow studies. We are going to pre-treat these patients with anti-seizure medications, because with an increase of an intracranial pressure, there will be an increased risk of developing seizures. Any patient with a head injury or increased ICP is at risk for seizures. So prophylactic seizure meds will be started, okay? And they're going to be placed on seizure precautions. Even if they haven't had a seizure yet, we're going to implement these things. You have to be really careful with some of these meds, especially Cerebex, because if you give it too fast, it will cause hypotension. They're also going to be using corticosteroids to reduce inflammation, help reduce edema, fluid restrictions, mannitol. We talked about that before. Antibiotics if they suspect infection, Valium or benzos to help with anxiety. Okay, that's all preoperative treatments. Postoperative care, monitoring neuro status. The goal is aimed at detecting and reducing cerebral edema, relieving pain, preventing seizures, monitoring ICP, and monitoring neuro status. Okay, so we're going to be doing things like Tylenol, codeine, morphine for pain relief, Tylenol for temperature, steroids and mannitol to reduce ICP, monitoring urine output, positioning. All of those interventions that we've talked about before to reduce intracranial pressure are going to apply here. The patient is likely to be intubated, probably going to have an ART line and central lines. So you've got infection prevention, seizure precautions, airway precautions, pneumonia prevention, that balance between sedation and keeping them calm, and then letting them wake up slowly and gently, and monitoring the neuro status, assessing for neuro deficits. It's just a fine balance there. Some of our interventions specifically aimed at monitoring or maintaining cerebral perfusion. Monitoring respiratory status. Definitely want to avoid hypoxia or an increase in CO2, so we want to hyperventilate the patient, keeping oxygenated, watching the vital signs. Cerebral edema peaks within 24 to 36 hours, and they're going to have even more swelling post-operatively. So if they had increased intracranial pressure and we took them to surgery, then post-operatively they're going to have even more edema. So we've got to be diligent about assessing for neuro changes and implementing all those measures to reduce cerebral edema. In some cases, we will paralyze these patients just to reduce their metabolic demand. Strict strategies to control and reduce ICP, so that is limiting anxiety, limiting environmental stimulus, no visitors, dark room, seizure precautions, positioning, all that kind of stuff. Very, very important. Regulating temperature, especially after surgery, they're at risk for an elevated temperature because of inflammation. And then if an infection sets in, then that's even, a greater risk there, and they already have a compromised autoregulatory structure, so elevated temperatures have to be treated very vigorously, and we've got to implement those measures to get them cool, not just giving them Tylenol or ibuprofen, but active cooling measures. And then, of course, maintaining gas exchange. Remember, we do not want ischemia, hypoxia, because that leads to increased intracranial pressure. So going back to oxygenating, turn, cough, deep breathe, incentive spirometry if they are not intubated. If they are intubated, then gentle suctioning, coughing cautiously. Definitely want to implement all nursing interventions to promote gas exchange and prevent infection and keep them oxygenated adequately. Sensory deprivation, many times with these type surgeries, they're going to have periorbital edema, so they won't be able to see, or they won't be able to see very well. So you've got to implement all of your good therapeutic techniques so that you don't scare them to death when you walk in the room. Protecting the eyes, measures to reduce periorbital edema, and then helping them with the psychosocial aspect of it, self-image. Many of these patients with craniotomy or cranial surgeries, we've had to shave their head, so they've got appearance issues, social interaction, especially with teenagers, kids. They've got social interaction, stuff like that. So, you've got to address the psychosocial aspect of all of this too. Of course, that's once the patient's intracranial pressure is stable. We're not really worried about a wig and combing their hair when their intracranial pressure is through the roof and we don't know if they're going to be okay. So it's all in order of priority. Other interventions, monitoring for bleeding. We've talked about increased ICP already. Managing fluid and electrolyte disturbances. Don't want them too dehydrated, but you don't want them too volume overloaded either. So, possible fluid restrictions, and then slowly resuming oral intake once they can swallow and they have a gag reflex, monitoring for all of those variations, diabetes insipidus, SIADH, instituting the nursing interventions appropriate to each of them. You also have to be diligent to assess for things like hyperglycemia and stress ulcers, because many times these patients have been on very high doses of steroids for an extended period of time, and if they are already diabetic, then their blood sugars are going to be out of control, and then they also are at risk for developing GI ulcers, stress ulcers, because of all of the steroids and then the amount of stress they've been under. So you've got to be diligent in assessing not just the neuro status, but the whole patient, that holistic care. Preventing infections, monitoring for seizure activity. Definitely in your assessment, you want to be aware of areas, incisions that look like they're leaking, or a dressing that has drainage on it. You've got to assess any drainage as a potential leak of CSF, okay? Especially if the patient tells you that they have a salty taste in their mouth, or if they've got a lot of postnasal drip. That could be an indication of CSF. So that would definitely be something that would need to be tested, or the doctor notified. Patient teaching about how to cough, sneeze, blow their nose, very strict aseptic technique, and then managing for other infections related to the surgical site. Seizure precautions. Seizures are an abnormal episode of motor or sensory activity, sudden, uncontrolled electrical discharge from the cerebral neurons. If you look at chart 66.3, kind of goes into the different types of seizures. Partial seizures are just one part of the brain. We have simple partial, where a simple seizure means they are still conscious, and then a complex seizure means that there was a loss of consciousness. So, just knowing the differences in those, and then generalized seizures involve the whole brain or all brain activity. Seizures lead to a loss of consciousness, excess movement in muscle, or loss of muscle tone, so they can actually have that abnormal muscle jerking, and then they can actually just lose all tone completely. And then there can be a disturbance of mood, behavior, perception, sensations. It's just altered neurologic function. Specific causes of seizures can be cerebrovascular disease, hypoxia, fever, metabolic disturbances, toxic or toxicologic issues like drugs, overdose. Certain medications can induce seizures, tumors, alcohol, lots of different reasons. Seizures can be idiopathic, meaning born, a congenital problem, or they can be acquired because of a head injury or a disease process like a tumor. So it's important to know, have they had it for a long period of time, or is this new, and can it be linked to a certain event? Nursing management, of course, observe and document the patient's activity, their signs and symptoms before, during, and after the seizure. You want to assess for all of the, all those things, circumstances, what were they doing. After the event is over, can the patient tell you, do they report that they had an aura? Sometimes they will have a sense or a feeling that's characteristic immediately before they have a seizure, and that's their aura. So you would want to know if they can report that. What was their behavior? at the onset and during the seizure activity? Was only one part of the body involved? Was it the whole body? Did they lose consciousness? Did they not lose consciousness? Were they incontinent? How long did it last? Um, you've got to document all of those things. And then, of course, keeping them safe during the seizure so they don't hit their head, making sure that there's no physical injury to them during the seizure, and then post-seizure care, assessing for complications. You want to maintain airway. So many times a patient after a seizure will vomit, and so you've got to make sure that you prevent aspiration, so to get them side-lying. If they are upright, standing up or sitting up when they begin seizing, you really want to try to get them down on the ground, laying down, or at least sitting down so that they don't hurt themselves. And then after seizure, they're going to have that post-ictal state where that's kind of like the recovery phase for the brain. It can be anywhere from 5 to 30 minutes depending on the type of seizure that they had and the area of the brain that was involved. And it also depends on how long the seizure lasted as to how long the post-ictal state will be. But that's that recovery phase. The brain has to kind of get back to normal after all of that hyper activity of the brain cells. So during that post-ictal state, you have to assess for hypoxia and safety, and then, like I said, aspiration. Epilepsy is a term that characterizes a group of syndromes, or a syndrome characterized by unprovoked or recurring seizures. Epilepsies are classified by pattern, age of onset, family history. They can be idiopathic or secondary to disease, like I talked about before. Drug therapy is the key to management. The goal is to control seizures with the lowest dose of medicine possible and with a medicine that has the fewest side effects. So the moral of the story is, if it works, use it. Don't change it. You don't ever want to, if a patient has been on a seizure medication and they haven't had any seizures in a very long time, they are not cured. You don't want to take them off of it. That means it's working. Okay? So pharmacologic therapy is key to management. Dose effects, blood levels, dose adjustments, that's all based on patient status. Okay? So like Dilantin and phenobarbital, they have blood levels, and those blood levels need to be checked on a frequent basis. Some of the newer drugs, Keppra, Cerebex, they don't have blood levels. So it's important for you to know which drugs have blood levels that need to be monitored, the side effects of those medications, and then any dose adjustment that has to be made based on blood levels, patient's weight. If they gain weight or lose weight, then we need to adjust. And then anything that affects seizure activity. So if they have an increase in seizure activity, then we need to reevaluate. Okay, the patient needs to be taught to notify the doctor. Also need to be aware, you and teaching the patient, signs of toxicity, drug toxicity, especially with Dilantin. Status epilepticus. Sorry, I have to have a drink of water. All right, status epilepticus is acute prolonged seizure activity without full recovery of consciousness. It's not necessarily one long continuous seizure, but it is the absence of full recovery, meaning the patient does not completely come back around. It can be, usually status epilepticus is triggered by abrupt withdrawal of seizure meds. Okay? It can be caused by fever, infection. sepsis, things like that. But most of the time, it's because the patient ran out of medicine, or they went, the doctor maybe took them off of it for some reason. They went to a new physician, or just an abrupt withdrawal of those anti-seizure meds. It is a medical emergency. It must be dealt with immediately because it can impair respiratory status and lead to hypoxia. So our goal is to stop the seizure activity as quick as we can and then maintain oxygenation status. Requires thorough and ongoing assessment. You've got to document all of those characteristics of seizure that we talked about before, and then specifically the time that the seizure started, how long it lasted, any specific characteristics that are key, part of the body, and then especially about the postictal state and that level of consciousness. The key here to management is timely administration of medications, okay? So when we're teaching our patients, when we're getting them squared away, if they're new onset seizure activity, then we've got to establish a schedule for our meds that's consistent. We should not vary the times or skip doses. A blood level has to be maintained. So we've got to teach the patients the same thing. They should never skip doses. They should take them at the same time every day. The patient needs to be taught what to do if they're sick. If they have a stomach bug and they can't keep anything down, they've got to be taught what to do. Notify the physician. If they lose weight, the dose may need to be adjusted, so they've got to notify the doctor. If they run out of their medication and they can't get to the pharmacy, they need to know, call the doctor. So very important patient teaching points here. Okay, so now we're in Chapter 68. We're talking about management of patients with neurologic trauma. Our objectives are, we're going to be talking about the different types of injury, their symptoms and signs and manifestations and testing and treatment, and then nursing management related to brain injury, and then nursing process related to brain injury. All right, head injuries are just kind of a broad classification that we use to talk about different things. It can be a scalp injury, which is very superficial. It can be skull injury, which is the actual bone structure, or the actual brain tissue injury, okay? So when we say head injury, I just need you to know that it can be any one or a combination of those three components. The most common cause, head injuries are the most common cause of death from any kind of trauma, and the most common cause of brain trauma is from a motor vehicle accident, an MVA. And of course, our highest risk group are males between the ages of 15 and 24 because they are risk takers. The very young and the very old are also at risk as well, and that is mostly due to balance issues. Younger than 5 years of age, toddlers, balance issues, running into things, and then same with the elderly, balance issues, falling, hitting the head. Those are all an increased risk in those age categories. So prevention is the major key, okay? If we want to, the best way to treat a head injury is to prevent a head injury. Just a little pathophysiology here. Primary injury is the initial damage that's done. It's due to the actual insult or the actual injury. It is the original problem. Primary injuries can be contusions, lacerations, damaged blood vessels, They can be acceleration or deceleration injuries, penetration from a foreign object. It can be, whatever that initial insult is, causes primary injury. And then the secondary injury is any damage that results or evolves after the initial injury as a result of edema or ischemia or chemical changes that lead to trauma in the brain. So a secondary injury is any damage that occurs after the original insult. Manifestations of our scalp wounds: bleeding, because the scalp is very vascular. They tend to bleed very heavily, and it's a source of infection. So the way to handle a scalp wound is direct pressure, stop the bleeding. If it's large enough, then suture or staple, okay, to close it up. Skull fractures can be classified as simple, comminuted, depressed, or basilar, and then they can be open or closed. Okay, a simple skull fracture is just a straight line. It's nothing fragmented, it's just a straight fracture. Comminuted means it's splintered or there are multiple fracture lines. A depressed skull fracture means that the area where the break is actually sunken in or depressed toward the brain. And then a basilar fracture is at the base of the skull, okay? So it involves it's at the base of the skull, okay? And then open and closed refers to broken skin or no broken skin, okay? So if it is a closed, depressed skull fracture, that means there's no broken skin and the area has been pressed inward toward the brain. Skull fractures usually have very localized and persistent pain, may or may not have any swelling. Fractures at the base of the skull tend to cause bleeding from the nose, ears, eyes. In the pharynx, they will often manifest with battle sign, which is bruising behind the ear, ecchymosis over that mastoid process, which is behind the ear. And then also you could check for a halo or halo sign, which is indicative of a CSF leak. And what that is, sometimes there'll be fluid that drains from the nose or the ears, and we're not sure if it's CSF or if it's mucus. And so, you would get a drop of it, and you look, if it's CSF, the center of it is going to look like a blood stain, and then there will be a very distinct, clear ring around that center blood stain, and that ring is called a halo, and that's indicative of CSF. So basilar fractures are most common at the temporal area in the occipital regions, and that bleeding from the nose and the battle sign are your very key findings. Assessment diagnostic findings, physical assessment, of course, you're looking at neuro status, looking for any signs of neurodeficits, wanting to know, what was their baseline neuro status. Physical assessment findings, vital signs, signs of injury, open or closed, anything on the face, are there, do they have any drainage from their nose, ears, eyes, battle sign, any bleeding. You want a very thorough neuro exam. Respiratory status, and then of course X-ray, CT, MRI are going to be used to confirm the fracture. or any kind of injury that has, is going on. Cerebral angiography, looking at blood flow and checking for any damage to vessels. Medical management, non-depressed fractures generally don't need any kind of surgery, just close monitoring for increasing ICP, neuro changes, just monitoring and allowing that to heal. If it's a depressed skull fracture, then it does require surgery because they need to elevate the part of the bone that's compressed in, because it can damage actual brain tissue or blood vessels. So if it's a depressed fracture, they definitely are going to operate on that. Brain injuries, very important to consider that there could also be a brain injury with a head injury. Okay, so you have to differentiate brain injury versus head injury. So whenever there's a head injury, it's very important for you to determine if there is brain injury also. Clinical manifestations of brain injury: altered level of consciousness, obviously, pupil changes, sudden onset of neurodeficits or a neuro change, any change in sensation or balance, movement, reflexes, things like that, changes in vital signs, sudden headache, or onset of seizures. A closed brain injury usually is the result of blunt trauma. Typically, it's an acceleration or deceleration injury, also known as coup contra coup, meaning that there is an injury because the patient is like in a car and they're moving at a very rapid rate of speed, and there is a sudden deceleration, okay? So the head accelerates and then rapidly decelerates, damaging the brain tissue. So what happens, it makes the brain actually go toward the front of the skull. It damages the front of it, and then when there is that sudden deceleration, then the brain actually hits the back of the head, and it's a forward and a backward, or a coup contra coup injury. Open brain injuries are like penetrating, stabbing brain trauma. Okay, so it is so severe that it not only penetrates the scalp and through the skull bone, but into the brain tissue. The dura is actually penetrated as well. Contusions. A contusion is classified as a mild traumatic brain injury where there is a temporary, concussion, not contusion, concussion is what I'm talking about first. A concussion is a mild traumatic brain injury where we have a temporary loss of consciousness but no apparent structural damage of any kind. Okay, so this is, the football player that gets hit in the head, he gets knocked out, that temporary loss of consciousness, and then he wakes right back up and he doesn't have any kind of obvious injury to his head. Okay, no structural damage. A contusion is classified as a moderate to severe traumatic brain injury. It's a more severe injury with possible hemorrhage. Symptoms and recovery, it depends on the amount of damage and the associated, if there's any cerebral edema that develops after the fact. A lot of times it's not the contusion itself that causes the problem as much as that secondary edema, that secondary injury from edema that results in brain damage. In a contusion, the brain is not only bruised, but it is damaged, and like I said, it's often from a secondary injury. There's a longer period of unconsciousness, more neurodeficits, more changes in vital signs. It's just a more severe type of traumatic brain injury. Diffuse axonal injuries are where there is widespread axon damage with head trauma, and the patient will develop an immediate coma. Typically, in a diffuse axonal injury, that means there's not one identifiable, one local source spot. There's no focal lesion or focal area. It's just kind of a widespread, diffuse injury. It can involve all parts of the brain, the cerebrum, corpus callosum, brainstem. It's kind of just generalized, I guess, diffuse, okay, injury. It's typically caused from widespread shearing or rotational force. So it can be, trauma, but it would have to be like a repetitive, I don't know, I keep thinking of just somebody getting hit in the head over and over again. But it's a widespread, generalized type of damage. Intracranial hemorrhage can be broken into 3 or 2 categories: epidural hematoma and subdural hematomas, which we're going to go into in depth in just a minute. That's intracranial hemorrhage, and then intracerebral hemorrhage and hematoma is bleeding from trauma or a ruptured aneurysm in the cerebral vessels. So there's actual bleeding inside brain tissue, okay? That's intracerebral, okay? So some nursing interventions for traumatic brain injuries. There's your list. So make sure you review, and I'm not positive that those page numbers are accurate. My apologies if they're not. But neurofunction, of course, assessing neurofunction, monitoring for changes, monitoring for a patent airway, making sure the patient can maintain their own airway. Again, with brain injury, there is that possibility of secondary swelling, which can lead to increased intracranial pressure and all of the problems that come along with that. So very thorough assessment and monitoring for increased intracranial pressure, fluid and electrolyte disturbance, secondary injury, temperature, safety, all of that stuff. And then patient teaching, support, coping, because this is going to be a long process of recovery. So there's a lot of family coping and teaching support that goes on. Okay, so if we're talking about intracranial hemorrhage, the first type I told you about was epidural hematoma. So these intracranial hemorrhages, this is not actually bleeding inside the brain tissue. This is bleeding that is between the bone, the skull, and the dura, which protects the brain tissue. So it's in that space between the brain and the bone, okay? Epidural or extradural means on top of the dura, okay? The patient may experience brief loss of consciousness, and then they return to a very normal neurologic state. And it's typically a very, very brief loss of consciousness. It's nothing that is more than a couple of minutes, 5 minutes at the most. and then, they're right back. It's maybe not even that long. The problem is that they've got a bleed going on. So as this hematoma, and it's internal, so you don't know about it, but as it grows, as the hematoma expands, it increases intracranial pressure, which in just a very short time, over a couple of hours, 3 hours or so, you begin to see neuro changes, restlessness, agitation, confusion, and that progresses until they have major signs of neurologic change, and it progresses into coma and just onset of herniation. Initially, after, they have that brief loss of consciousness, when they wake up, when they return, they come right back, and they say they feel fine. They're okay. And many times in these cases, these patients refuse to go to the hospital because they wake up and they feel fine. And then typically within 6 to 8 hours, they have profound neurologic deficits, altered level of consciousness, severe headache, nausea, vomiting, and it progresses to further increased intracranial pressure, respiratory problems leading up to respiratory distress, respiratory arrest, and then brainstem herniation. Okay, so anybody, any situation, any patient that gets hit in the head, baseball, football, fall down and bump their head, fall on the floor and hit their head, or I've known a patient who, like in the kitchen, hit somebody, opened the cabinet door and hit him in the head. If it's hard enough to knock them out, even briefly, even if they wake up and they say they're fine, they need to go be scanned. They need to go to the hospital. They need to have a CT. Because this bleeding, you only have a few hours, and then the bleeding increases so much that it alters their ICP, and it can really have a bad outcome here. Okay, an example, y'all like to relate it to famous people or stuff like that. An example of this type of hematoma, epidural hematoma, is Natasha Richardson. She was an actress, and very well-known actress, was married to Liam Neeson. And if you have kids, she played in that movie with Lindsay Lohan about the twins, where Lindsay Lohan and Dennis Quaid, anyway, I can't remember the name of it. Anyway, long story short, she and her husband went on a ski trip. She was out on the slopes skiing. She slipped down. She hit her head on a rock, knocked her out. A couple of minutes, woke up, got up, felt fine. Refused EMS, refused to go to the hospital, went back to their hotel room, and within about 6 hours was unconscious. By the time they got her to the hospital, she had herniated and she died. So it's very profound. It's very fast. The treatment for epidural hematoma is to reduce intracranial pressure. So it's a burr hole, typically, or craniotomy, but it's get in there, open up the cranium, the head, relieve the pressure, stop any bleeding, or remove any blood clots that might be there. Subdural hematomas are a collection of blood between the dura and the brain, which the term subdural, or under the dura. Okay, again, it's not actually bleeding in the brain tissue. It's not intracerebral, but it is between that layer of the dura and actual brain tissue. Most often they're from trauma, but they can also be from a ruptured aneurysm or coagulopathies, meaning maybe the patient is on Coumadin and their INR is too high. It can be from other types of blood thinners, Xarelto or the antiplatelets, Brilinta, Plavix, anything that alters coagulation. If there's a weakened vessel that begins to leak, or if there's an aneurysm, it could rupture. So subdural hematomas are very common in the older population because of weakened vessels, aneurysms or coagulopathies and hypertension. You put those things together and it often equals subdural hematoma. So there are two types of subdural hematoma, an acute or subacute, and then there's chronic. Okay? Acute subdural hematoma typically develops over 24 to 48 hours, and then the subacute symptoms will develop 48 hours to up to 2 weeks. So it's very slow developing. Okay? Even the acute takes a day or two for symptoms to develop. Okay? But with this acute subdural hematoma and a subacute subdural hematoma, you have to they need craniotomy. They need a burr hole or something to control that intracranial pressure, or they are going to begin to manifest all of the signs of elevated ICP. Again, that would be trauma, motor vehicle accident, or fights, getting hit in the head, stuff like that. A chronic subdural hematoma, this is the one that is most common in the elderly population, can develop over a long period of time, 3 weeks to months. Okay? It is not fast developing. Usually the cause of injury is very minor. Again, getting, hit with a cabinet door, bumping your head, bumping into something. It's very minor, and it's often not even thought of. The clinical signs and symptoms are very vague. They fluctuate. The treatment is not evacuation of the clot. That is not correct. Treatment is what they call watchful waiting. So it really depends on the size of the hematoma, if it's growing, if it's getting bigger, how quickly it's getting bigger, if there are any symptoms, if the patient is symptomatic in any way. If there is evidence that it's getting bigger and the patient is symptomatic, then they will do a burr hole to relieve the pressure and extract the clot. If the patient is stable and there's not any signs that the hematoma is getting any bigger, the patient doesn't have any kind of neuro symptoms, then they won't do anything. Often they'll just let it sit, and the body will actually reabsorb all of that blood on its own. So it kind of just depends on patient presentation. If they're symptomatic, if there's any neuro deficits, and they might do a CT scan and then 2 or 3 days later or a week later do another one, or do one now and do one in a month, just to see if it's growing. And if it's not, they're not going to do anything about it. Intracerebral hemorrhages, these are the actual bleeding into the brain, in the brain tissue. They can be traumatic or non-traumatic, MVA, a fall, something like that, or non-traumatic, meaning a rupture of an aneurysm, coagulopathies, tumors, uncontrolled hypertension that leads to a rupture of an aneurysm, stuff like that. Okay, our treatment here is very supportive in nature. monitoring respirations, blood pressure, heart rate, if they're in a critical state. If they are stable, then our treatment, our supportive care is more emotional in nature. Implementing measures to control intracranial pressure. Control of blood pressure is essential here. If it's coagulopathy related, then we definitely want to control blood pressure as well as treat the coagulopathy. Sometimes those coagulopathies are the direct result of medications like Coumadin, which can be easily reversed. And sometimes the coagulopathies are from things like liver failure or a vitamin K deficiency that may not be as easily reversed or taken care of. So not only are you given fluids and electrolytes and then blood pressure medicine, but you're also giving things like FFP, platelets possibly, methods to control bleeding. Possibly looking at craniotomy to remove the blood clot or control a hemorrhage if it's really big, but it may not be possible to do craniotomy depending on the location of the bleed, because remember, these are intracerebral, so we may not actually be able to get into that tissue to control the hemorrhage. So this is a good description of the three bleeds that I just was talking about. So if this is the skull, this is our outer edge here, and then this gray part is the dura that separates the skull and the brain matter. Epidural, or on top of the dura, as you can see, it's between the bone and the dura. Okay, so it's on the outside part. It's external to the brain dura. It still can cause shifting. It can, as it grows, it can still push the brain tissue over, but it's easier to get to. Now the subdural, as you can see, here's our skull, and then the gray is the dura, and then here's our brain tissue. So the bleeding is actually under the dura, but still not in the brain yet. So yes, it can still, as it grows, it can still shift brain tissue over, and that can mess with our ventricles. But again, it's not as easy to get to as an epidural hematoma, but it's still easier to get to. This is our intracerebral hemorrhage, which is inside, smack dab middle of the brain. Hard to get to. And as you can see, the bigger it is, the more effect it's going to have on the surrounding structures. So just a good visualization of these different types of bleeds. Management of brain injuries in general, of course, physical exam and neuro exam. You want to know what kind of symptoms are they having. What is their baseline neuro status? Now remember, if you're in the hospital and this patient comes in with a brain injury, you may not, what you see in terms of their neuro status might not be normal. And so the only way that you're going to get that good baseline is to talk to the family. Your baseline from your assessment is going to be whatever you see at that time. So all of your changes are going to be referenced according to what you see when you admit that patient or the first time you have that patient. The family can give you insight. They can tell you, no, this is not normal for them. He wasn't doing this 2 hours ago. You know, whatever the case may be. But however that patient presents, the first time you see them is your baseline, and all of your reference goes from that. You can expect CT, MRI, angiography possibly. You can assume cervical spine injury until it's ruled out, which means you don't do anything with the neck. You know, in CPR we do that instead of head tilt, chin lift, you're going to do that jaw thrust where you cervical spine stabilization and just lift the jaw. All of your interventions and treatments are going to be aimed at preserving cerebral blood flow and preventing secondary injury from edema and hypoxia. So just remember all the interventions we've already talked about. Treatments for increased ICP are going to be applicable here, and then all of our supportive measures in terms of family support, and then evaluating for brain death. Supportive measures are going to be, like I said, respiratory support, intubation, mechanical ventilation, seizure precautions, definitely doing prophylactic seizure, anti-seizure medications, going to be started right away. Even if they haven't had a seizure, you want to get them started. NG tube to decompress the stomach and prevent aspiration. If the patient is not intubated, well, even if they are intubated, you want to do measures to control pain and anxiety. You want them to be calm, but you want to balance that and use it with be very cautious with your sedation, because you don't want to over-sedate, because that will mask any neurologic change or neurologic impairment that might happen. You wouldn't be able to see it because they were sedated. Brain death is another thing that we have to monitor for, assess for. You know, brain death is just incompatible. Brain injury that's incompatible with life. Irreversible brain injury. Irreversible loss of all brain function, including brainstem activity. A patient cannot be declared brain dead if they still have brainstem activity. They don't have any higher level cognitive function, but brainstem activity does not constitute brain death. So our three cardinal signs of brain death are persistent coma, where the patient is unconscious, unarousable, and completely unresponsive. Absence of brainstem reflexes, which are your deep pain reflexes. So there's no response to deep pain stimulus. There is no corneal reflex. When we do our corneal reflex testing, there is absolutely no response. There is, they're going to do the doll's eyes test, and then they're also going to do what's called a cold caloric exam. And that's where they actually, in a patient who doesn't have any response to deep pain stimulation and does not have a corneal reflex at all, then they actually inject ice water into the ear with, they'll use a big syringe like you would use on an NG tube, and they will draw up ice water, and they actually inject it into the ear of the patient. And if their brainstem is intact, that cold ice water stimulus will actually cause the eyes to, they'll have nystagmus. They'll track to the side where you inject the ice water. They kind of deviate toward the area where the irritation is. If brainstem is not intact, the eyes don't move at all. So again, that cold caloric or that ice water challenge is just, it's such a irritating stimulus that if there's any brainstem function at all, it'll cause the eyes to deviate toward that side. And then last, and probably the most important, is the apnea challenge, the apnea test. NIH.gov National Institute of Health, they have a really good discussion about apnea challenge, but it's essential that an apnea test is done. They have to be removed from the ventilator. At this point, they're going to be intubated. If we're at the point of evaluating brain death, this patient is intubated. So we have to remove them from all ventilatory support so that we can evaluate whether or not they have spontaneous respirations. There's criteria to do an apnea test. First of all, they have to be pre-oxygenated on 100% oxygen for at least 10 minutes. The patient has to be normothermic. They cannot be cold. They have to be of normal body temperature. They can be warm, they can be slightly febrile, but they cannot be hypothermic. So they have to be at least 98.6. And then there cannot be any paralytics or sedatives or any kind of neurologic altering medication on board. It all has to be stopped for a period of time and allowed to get out of the system. Okay, so they'll pre-oxygenate 100% O2 for at least 10 minutes. Once the patient is normothermic and or not cold, not hypothermic, and then all of the sedatives and paralytics have been stopped. They disconnect them from the ventilator and they wait. So a positive apnea test means that there is no spontaneous respiratory effort when the CO2 level, the PCO2 level, is greater than 60, or there's no spontaneous respiratory effort when there is greater than a 20 millimeter increase over the patient's baseline CO2. So that accounts for your COPD patients, okay? We all know that a lot of times a COPD patient has a chronically elevated CO2 level, and sometimes their CO2 levels are greater than 60. So if that patient's baseline, let's say, is 58, they live at a CO2 of 58, for them to have a positive apnea test means that their CO2 level at, if their baseline is 58, then at 78, once they get at 78 or above and there's no spontaneous respirations, then they can be considered brain dead. Okay? So an apnea test, a positive apnea test, equals brain death. All right, other testing that's going to be done, adjunct testing, EEG for sure. We're going to be looking at brainwave activity, and there will probably be multiple EEGs. Okay? Typically, they want at least 2 that are negative for any brainwave activity. Also going to do CT, MRIs for scans, showing if there's shifting or brain damage, tissue damage. They're going to have those, and there probably will be multiple of those as well. But as you can see, to make a diagnosis of brain death is not arrived at quickly or lightly. There are very specific criteria that are met, and in my practice, what I've seen is even though we know the patient's brain dead, we're still going to do another EEG. We're going to test one more time just to make sure, because that's a sad deal for the family. So our responsibility in all of this is to assist with the procedures that, as the doctor does his neuro exam and evaluates for brain death, we're there. We're the ones that are going to put all of the sedation on hold. We're going to be helping him as he does his neuro exam. We might be the ones, that are hyperventilating, hyperoxygenating and pre-oxygenating, whatever. We're going to be there. Definitely documenting all of these activities. The doctor will also be documenting in the progress notes, but we will also document in our nurses' notes what's going on, who's there, any family that might be there. Definitely providing psychosocial support, open communication with the families, about the patient's condition, their prognosis. Our job here is to answer questions openly and honestly. Use words that they can understand. Don't use a bunch of medical jargon that is difficult for them to understand. The doctor's probably going to do that anyway. So one of our jobs is to be there. And I always made a point when the doctor went to talk to the family, I went with him. And I listened to what the doctor said, and that way when he was done and left, if the family had questions, or a lot of times I would just say, okay, do you understand what he just said? And I would go back over it with them in a way that was easier for them to grasp. Number one, they're stressed out. This is a huge situation, and they are not going to remember what he said. So it's always a good idea to be there and be able to kind of recap and restate and go over things with them again, because they're not going to remember it. Okay? Don't make up things. Don't guess at things. If you don't know the answer to something, then just be honest and say, I don't know, but I'll find out. Or we'll figure out how to find out. Or we'll go talk to the doctor. I'll call the doctor and have him come back. If the family still has questions, if they're still not sure and they want to talk to the doctor again, and even though maybe he just left, you go call him again. Okay? That's our job. Open communication. Facilitating communication between the family and the MD. Like I said, if they want to talk to him again, you go call him again. Give the doctor the family's phone number. Dial the number for the doctor. I don't know. I've done all kinds of things just to facilitate communication. As far as end-of-life issues, once we know that the patient is, kind of at a non-recoverable state, then we need to begin talking to them about, family members. Do they have any kind of written not power of attorney, but living will, or do they have any kind of wishes or anything that they've expressed to the family? Do they want to be an organ donor? Is there a legal power of attorney that we need to know about? What religious beliefs, what traditions, what cultural traditions? Every culture has a different way of dealing with death. Are there any kind of religious or cultural leaders or spiritual leaders, clergy members that we need to contact? That is our responsibility. If there are some specific cultural or religious traditions that the family wants honored, then we need to contact social services. There's a mechanism for finding, those people and getting them there, as quick as we can. You also have to address things like, what funeral home does the family want to use? You've got to coordinate, once that determination of brain death is made, if the family decides to withdraw all their care, the ventilator and medicines and stuff, you've got to coordinate with the funeral home. You've got to coordinate whether or not the person has to, the coroner has to come. There's just a lot of things that have to be orchestrated. The family has to sign forms to release the body from the hospital to the funeral home and stuff like that. In the state of Louisiana, we are required, all healthcare providers are required to notify the coroner for any death for an admission under 24 hours. So if that patient has been admitted to the facility less than 24 hours and they die, it's an automatic coroner's case. Okay? If it's less than 24 hours from admission. Okay, let me say that again. If death is less than 24 hours from the time of admission, or if they've had surgery in the last 24 hours, then we are required by law to notify the coroner. The coroner has to evaluate the case and make a determination of whether or not an autopsy needs to be done. Many times, if the patient was sick already and we can give the coroner details over the phone, then he will go ahead and release the body and say, okay, it's fine, they can go. Often, the coroner will send out a representative from his office, and they will come to the hospital, they will review the chart, they will review the patient, and make a determination. But in either case, we cannot release the body to the funeral home, nor can we do organ donation until the coroner has released the body. Okay, so the coroner has to sign off first. Also, in Louisiana, the organ procurement, LOPA, Louisiana Organ Procurement Agency, has asked in the state of Louisiana that all deaths be reported to them so that they can screen the patient for potential donation. Donation doesn't have to just be organs. It can be skin, long bones, tissue, corneas, organs. There's a lot of things that can be donated today now. It doesn't just have to be organs. So LOPA asks in Louisiana that all deaths be reported, and then the LOPA representative will determine whether or not they can approach the family. Only LOPA approaches the family. We do not do that. We're not responsible for that. But if it's deemed that the patient might be a candidate for donation of some sort, then the LOPA representative comes out and they speak with the family. In the event that the family consents to organ donation or donation of any kind, once the coroner releases the body, then usually what happens when we know that the patient is a candidate for organ donation, we notify LOPA. The LOPA representative will come in and they will let us know what we need to do, because we don't withdraw the ventilator. A lot of times we won't stop medications because we want to keep the body, we want to keep blood pressure up. We want to keep circulation to those organs and keep them viable. But once they determine brain death and the coroner releases the patient, LOPA will talk to the family, and if they consent to donation, then as soon as the family signs the consent form, then all care of that patient gets turned over to LOPA. LOPA dictates the medicines that they get, because at that point the patient is brain dead. So the doctors on the case are signed off. Our nursing care ends. All responsibility for that patient is turned over to LOPA. And then they orchestrate the harvesting of whatever organs or tissues or whatever the patient has decided to donate. LOPA is in charge of orchestrating all of that. In cases of true organ donation, where we are going to do liver, kidney, pancreas, heart, lungs, things like that, that's a surgical procedure. The patient is they're left on the ventilator. They are left on their medications, vasopressors and things like that. They set up a time in the OR. They will transport that patient into the OR suite, and there's a surgical team who will actually do the harvest. It means there's a local representative there, but there is a doctor, a surgeon who actually comes in and removes the organs and the bones and whatever is being donated. And they have to coordinate with the areas where those organs are going, and those teams have to come in, and they will be there so that when that organ is harvested, it can immediately be given to the recipient team, and they can leave and go, take it to the appropriate person. As far as the family is concerned of the donor, whenever they're done, whenever the harvest is finished, they will pack the interior parts of the body for stability. If they've donated long bones, they will actually implant like rods, titanium rods or plastic rods, so that the patient physically keeps its own shape. The body structures keep their shape and form. They close all the incisions. They sew them neatly just like they would do any other surgery, and they really restore the patient's appearance so that the family can still have a funeral. They can still have open casket funeral if they want it. There's no, a lot of people refuse donation because they think it's gross dismemberment of their family member. And when in reality, when they're done, you can't tell that they've had anything done to them. It's just like any other regular person who's been, to the mortuary. So it's really an impressive thing, actually. But the families, they can have their closure, they can have their funeral, they can have their open casket if that's what they want. So, and that's really important. When you're talking to families about end-of-life decisions, that's an important thing to know. I mean, it's not our job to talk to them about organ donation, but sometimes those questions come up, and it's okay for you to say, they have a process, and you can still have a funeral, you can still have an open casket if you desire. So knowing how to get in touch with LOPA, knowing how to orchestrate those type things, being very familiar with processes in the state of Louisiana. If you go to a different state to practice, then their laws are going to be different, and you need to investigate, what are their laws concerning brain death? What are their laws concerning organ donation and, end-of-life issues? So I very much encourage you, if you're going to go out of the state of Louisiana, that you need to investigate those policies, because all I'm teaching right now is about Louisiana. Okay? Beyond all that, family support. Lots and lots and lots. Therapeutic communication. Shoulder to cry on. Boxes of Kleenex. You let that family stay in that room as long as they want to. Okay? In cases of organ donation, that's a little different, and LOPA will really help to orchestrate all of that. But if it's just a brain death situation and they decide to withdraw care, then you let that family stay as long as they want to. You have to control the environment. A lot of times there's a lot of family members, and it can get very tense and a lot of chaos, and so there is a need to maybe sometimes limit visitors or control that environment, but give them space, give them time, and then when they're ready, you can facilitate, contacting the funeral home and getting that process ready for them to be transferred to the funeral home. That's it's a difficult thing to think about. I know it's probably not pleasant to think about, but your attitude and communication with the family, your interactions with the family, a lot of times when we get to this point where we're talking about brain death and having to evaluate for brain death, even if it's something that's happened very quickly, from a traumatic injury, because of the intensity or the severity of the issue and the patient's acuity level, usually you tend to form bonds with the family pretty quickly. So, having a rapport with them can really be good. It can give you and them both closure, because this can be a really, really hard thing to deal with. So I know this is all a little morbid and probably not very pleasant to think about, but this is actually the end of this lecture. Sorry to end it on such a down note, but I really hope that you learned something about all of this, and really, if you have an opportunity to put it into practice, that you really think about the importance of therapeutic communication and,